It is my pleasure to introduce Dr. Shrey Modi. He is a board-certified colorectal surgeon. He earned his medical degree from All India Institute of Medical Sciences in New Delhi, India, and completed his general surgery residency at the University of Miami-Jackson Memorial Hospital in Miami, Florida. Dr. Modi did a fellowship in colon and rectal surgery at the Ferguson Clinic, affiliated with Michigan State University in Grand Rapids, Michigan, and currently works as a community colorectal surgeon with UnityPoint Health Iowa. He will be speaking to us tonight on anorectal for colorectal surgery. Go ahead,
Thanks.
Dr. Modi.
Thanks, guys. Can you hear me? Number one. All right. Thanks, Jordan. Thanks, Joyce. And thank you, Karishma. It was me who asked to do this because I was feeling like I've been listening to this for the last 2.5 years and I've not done anything to give back. So this is just an attempt to do that. If you like it, let me know. Feedback is essential. Most of the people know already about anorectal a lot. Like this is the same slides that go every year. So I wanted to do something where I found that, oh, I was surprised a little bit. Like this also happens. So my community is like basically I'm the only colorectal surgeon in this area, and then University of Iowa did not have colorectal for some time. So the referrals will not go there. Like they were not accepting referrals because they were still hiring and some people left. So a lot of sudden influx of the pathology came, and it was really nice to see all of that. So I'll try to share some. The one thing I learned during all of this fellowship is the anorectal surgery has a way of surprising us sometimes really badly. Like this is what I thought, and this is totally what it came out. And yeah, abdominal cases are nice, but these are some of the few cases that come right into the clinic when you start. I mean, you will get colorectal cancer and other stuff too, but anorectal is something that keeps, that's your bread and butter basically. So let's go. I'm not an expert. This is not a comprehensive presentation of all anorectal pathologies. I'll try to share some of the things that I saw. I've been only working for 1 year and 8 months. So hopefully I will be able to share some things that may be unusual. Basic facts, most of the patients have not been able to see their own anus in their lifetime, at least through direct vision. So they rely on people telling them, reading, or just suffering for some time before they actually come to you. So most of them will be attributed to hemorrhoids, and hemorrhoids are only 1/4 of all the perianal pathologies literature-wise, and also what I see. And the anatomy is complex. Sometimes it's confusing. I didn't even know about anatomy of this anus properly till before I was in like second or third month of my fellowship. Then I realized, oh, this is such different. Like there's a valve there, there's a pit there. So all small things, but if you connect the dots, then you're able to explain it to the patient because you know it so well. So be prepared to give a small educational talk every time when you see a patient about this. That's what they want to know, what's going on. Once they know it, then they will be easy to counsel it as well. So the anatomic anal canal, it's an embryologic canal. It starts from anal verge, which is the outermost skin folds or rugae, and then it's around 2 centimeter in length. This is important because this is an anatomical boundary. And then the surgical anal canal is a functional canal. That is because of different pressure zones. There will be higher pressure area in this surgical canal, and there will be lower pressure area or more retention space above it. So anal verge to anorectal ring is this based on just defecatory process. So if you have any tumor or cancer that is below it, then you can counsel the patients accordingly, and the chances of LAR syndrome are also higher if the pressure zone is breached. And it's approximately 4 centimeter in length. Anal verge, this is considered beginning of the anal canal. So this area right outside will be the beginning of the anal canal. It does not contain features of normal skin. That means there will be no skin appendages, no hair follicles. They do have some oil glands, which are pretty well developed in other mammals, but they are less developed in humans because we don't need to define territories usually. So, but those are the same glands that are found there. So instead in humans, they secrete that oily stuff that keeps infection away. And that's why we tell the patient not to scrub or wash their anus aggressively. This anal verge is 1 to 2 centimeter below the dentate line because this is part of the anatomical canal. So anatomical canal is 2 centimeters. So this is the lowermost portion. There is no visually apparent marking because it's just so sometimes hyperpigmented skin, sometimes there is no hair follicle, sometimes patients have a lot of hair, so then it is not easy to see it. But basically, when you see, and that's where the start of the anus is. And this is the distal most limit to measure rectal cancer. So whenever you do a flexig or a rigid sigmoidoscopy, this is the distal boundary through which we are measuring. Anal margin, it's a region. It's not a real anatomic boundary as well. And it contains features of normal skin like hair follicles, glands. So this is the skin that is present next to the anus or the opening. Begins at the level of the anal verge and transition up to 5 centimeters. So what I do is, and I'm pretty sure everybody else, because I learned it from someone too. So make it simple. Anything that I see inside the anus is intraanal with an anoscope or a retroflex C-scope. Um, Perianal, whatever you see after separating buttocks, and skin is what you see when the patient is lying on their left lateral position or standing up without separating their buttocks. And that divides the region into sides, left and right side, and then anterior, lateral, and posterior. So it's very easy to know what I did an exam on this patient in the office, what lesion I found at which area. Some of my people around here are also still doing the clock faces, but okay to use it, but you have to then say that the patient was in prone jackknife or lithotomy position because every surgeon might be different. And if they don't mention the position, then the clock faces are gone. You're mistaken with that. But our guidelines or teaching in the book is not to use clock faces anymore. The dentate line is it's a transition zone between the anal mucosa or the anoderm, and then above that is the rectum, and then between the two there's a transition zone. So embryologically speaking, it derives from the cloaca. Cloaca is derived from the ectoderm, and then the hindgut is derived from the endoderm. So this is where the endodermal cells meet the ectodermal cells. And it also encompasses the transition zone because it's not a straight line, it's going up and down. And it has a fairly distinct origin of nerve supply, venous and lymphatic drainage. So if the anal rectal cancer is coming on from the top because it is adenocarcinoma and broaching this line, sometimes the cells can actually go in the inguinal lymph node. I've seen one patient this year already, 41-year-old female, who had a left inguinal lymphadenopathy on my exam. CT scan doesn't read it, MRI does read it, but preserved fatty hilum. So I thought, like, why not just get an FNA, and it comes at adenocarcinoma. So not only it has upstages or tumor, but even if I have to do an oncologic clearance, then I will have to do the left-sided lymphadenectomy. So this was nice finding that I knew. Transition zone, it says squamo-columnar junction. This is where this is ectoderm, this is endoderm, they meet. And there you can find multitude of cells. So it can extend 6 to 8 centimeters. Some text says 10 centimeter upwards. So if you think, so I got a referral saying a GI found a tumor around 6 centimeter from the anal verge, 6 to 8, extends for 2 centimeters. And the biopsy is squamous cell cancer, P16 positive. And then like a tumor board, we are discussing this. And then when you see that, okay, this is where the transition zone comes in place, that you have squamous cells into that area and they can arise as squamous cell cancer. Treated as anal cancer, the patient did well with chemo and radiation with no recurrence. So this is where the fun starts. This is what it was different for me. It was nice to learn all of this in detail when I was doing my fellowship. So the columns of Morgagni is these long channels where the dentate line meets the rectal mucosa or the transition zone. Is these columns are known as the columns of Morgagni, and between the columns, the depth is known as the anal crypt. So if you see, this will make a V-shaped area, and the V-shaped here will be known as the anal pit. And these mucosal folds are unidirectional actually. So they act like a valve. So that's known as the anal valve. So 8 to 12 anal glands, they open in this area. And then the glands are located at the varying depths from the internal sphincter to the external sphincter, and majority of them are present between somewhere in the internal and intersphincter groove. And then 1/3 of the glands broach that area and end into the intersphincteric space. So this is important because the fistulas happen in particular relation to the cryptoglandular origin. Sphincters, the internal sphincter is continuation of the smooth muscles of the rectum. So these are the longitudinal muscles and the circular muscles that form a nice big thick area of higher pressure, which is considered internal sphincter. And it is provides around 50 to 60% of the resting tone. And this is the muscle we cut for this anal sphincterotomy. So since it's a smooth muscle, it should not do the movement of the typical skeletal muscle with a bovie. So when you are cutting with the bovie, I do it with the bovie, then I know that this is the right fiber I'm cutting. That's one of the tests I dictate in my note to kind of tell that this is what I have cut, and this is also did not move or fasciculate with electrocautery. External sphincter, this is a continuation of the levator muscles, and the deep part is intimately related to the puborectalis ring, which is at the anorectal junction. And that's where the surgical anal canal ends, and that's also the acute angle of the anus. So this skeletal muscle is important for voluntary contraction, for on-demand squeeze. It is also part of the rectoanal inhibitory reflex. What that means is when the rectum gets all distended, then the first thing that happens is contraction of the external muscle, and then sudden increase in pressure of the anal canal. So that's rectoanal inhibitory reflex. And then the resting contractile activities, like people are trying to squeeze, lift something, it works with that. And it provides 30% of resting tone. And the maximum time that people are able to keep it squeezed is 30 to 60 seconds. It's a skeletal muscle, so it gets fatigued. So if you are bowing this should fasciculate or move. So you know that you're cutting this muscle. Taking history, you know this, and with time you will be able to make an educated guess about the diagnosis. And more importantly, you will develop a gut feeling about whether the patient will benefit from the surgery. You just know these patients that if I operate on this particular person's anus, then I'm not going to be doing any favors. And then turns out this might be a little bit more than what I can help with surgery. Ask leading questions. Patients are hesitant to talk about this, and most don't look forward to seeing their anorectal surgeon. This is true. It's a small community where I work. I meet the patients in the clinic, and then sometimes I meet them in the grocery store. And every time the people who say hi in the grocery store are the ones that I've operated on their abdomen, removed a cancer, diverticulitis or something. But the patients, actually two of them that I did anal surgery, did not say hi, and then came up in post-op or some other time in follow-up and said, "We are sorry. We just didn't want the people to know that we we had our surgery done." So it is funny. They apologize, but you have to ask the questions. Trying to say that they will not be able to tell you all the things that you're looking for in the go. So you have to probe it. Most people are not comfortable saying. They will not say anus. They will use different words to describe it. So I always ask for what is their goal from this visit. And some of the times it's just that people want to know the diagnosis. They said, we read in the paper that the cancer is increasing and we are having bleeding. Our doctor says it's hemorrhoid. I just want to make sure it's not something else. And that's it. He's okay with hemorrhoid. That's not what he's here in the clinic for. The few things I always ask about is anticoagulants, prior anal surgeries, pelvic radiation. I try to avoid doing a whole bunch when there is pelvic radiation. I don't retroflex my scope when there's pelvic radiation during colonoscopy. Last colonoscopy, when it was it, a good colonoscopy that you can rely on is very important, because you want to make sure if you can offer colonoscopy at the same time, if you are doing their anorectal surgeries, it helps two ways. One, you get the diagnosis. Like I diagnosed 2 Crohn's disease in fistulas because of this habit of doing colonoscopies. And the second, during hemorrhoid surgeries, I've found the people who have done a full prep, they tend to do better with terms of defecation and fecal symptoms, basically, of the pain, than people who just get 2 enemas and get the hemorrhoid surgery. That's what I've seen, but I don't have any literature to support it. Bowel habits and time spent on toilet. Physical exam, it needs to be gentle with good lighting. And for bigger individuals, I use an assistant. I always do female exams as everybody does with a chaperone, but sometimes even for males, even if they are a little bit on the heavier side or their big buttock cheeks, then I use assistant. I just got one shot. I tell them to take deep breaths. I fold their pillows so that their head is resting nicely, so we can do the best exam in one go. Left lateral is best for me in clinic or ER. An inspection is more important as feeling. So you just see, I look at the anus from front to back, from side to side, and just kind of orient myself. Then I palpate from outside to the anus, because if there's a pathology, or I ask the patient to point it out first so that I don't feel from there, because once you give pain or something, then it's very hard for them to relax again. And then you have to tell them, calm down, and then go deep breaths. DRE is the last step, but it needs to be thorough. I always check for relaxation and augmentation with squeeze, especially if I'm going to do a sphincterotomy or a fistula surgery. I look for any tracts with the fingers, the linear or curvilinear, and any dips on the finger when I'm coming out to make sure there is no internal opening or is that I'm feeling any polyp or rough area on the skin when I'm coming out. Lastly, anoscopy. Anal canal is angled anteriorly. How do I explain? This is the rectum. This will be the anal canal. So it straightens out when people go to the defecation process. So don't head in direct straight in, head towards umbilicus, because if you push directly in the line of the anal canal, which is straight, then you can cause pain. So angle it a little bit towards umbilicus. I'm pretty sure you guys know this, but it was nice to remind it sometimes. Start the endoscopic exam where you think the pathology will most likely be based on your DRE and based on what you have seen from outside. Because if the patient starts having pain, you at least have some good idea that you were able to see that particular area. Let's start with the common pathologies. External hemorrhoids. They have acute onset of severe and persistent pain. The pain doesn't go away because it's the skin under stretch. Operative treatment is best if it's restricted in first 3 to 4 days, and need to evacuate all the clot by excision. So sometimes in the ER, they lance it and they literally lance it. There's like poker and things will get better, but you got to excise the skin ellipse so that all the clot comes out because there's a very high chance of rethrombosis if there is some clot left behind. And even with that, you have to counsel the patient, this may start hurting again. In that case, either they reach out to the office or they come to the ER for more further management. Internal hemorrhoids, you'll see a lot of times from me when I get referrals, the bending has already been tried. It has failed, and then the patient has come to me. Or sometimes the patient do come and they ask for, can we get that bending? Because they don't know what they have, but told they have hemorrhoids. So I avoid bending. Actually, I do less bendings than I do excisional hemorrhoidectomies in my practice. But I avoid bending specifically in anticoagulants, even when there is aspirin 325 milligrams, because there's not much I can control besides applying the bend and removing the bend. I can't oversew, I can't do a whole bunch. With excisional hemorrhoidectomy, I do it on aspirin because you have more instruments and more things to control at that time. And then patient also anesthetized. Debilitating patient, that means they can't even sit or they're bedridden or they're wheelchair bound, there's no point. Then blood dyscrasia and neutropenias, because these bends can form abscesses sometimes. And then immunodeficiency, AIDS, after florid HIV infection, transplants, patients who are on prednisone more than 20 or chemotherapy. I just don't bend those people. Excisional hemorrhoidectomy, most important is counseling for this particular procedure. I've realized the more I counsel the patients in the office, somehow they do better after surgery. I spend time with them. I tell them one or two things at most to follow after surgery, like don't strain. You may feel that there's something sticking inside, but don't try to evacuate it. Just take your fiber, Miralax, and make sure you don't strain and spend more time on the toilet. I do it with ligation, and I always put local before excising for the hemorrhoids. For the fistulas, I put local after identifying the tract because sometimes it can make the tract distorted. And I do a closed hemorrhoidectomy, and I prescribe Flagyl 500 BID for 5 days post-op because I don't have the gel here. It is compounded, and the compounding pharmacy is not compounding it here. I don't do stapled hemorrhoidectomies. The new guidelines that came out in clinical practice also does not recommend it anymore. But this is just a recommendation. You do what you're good at. I'm not good at staple. I only saw 3, 4 of those in my fellowship, and I've seen more patients with complications in the community than. So I just don't do it. I only did it during fellowship. I've not done it afterwards. Anal fissure. Actually, this is the most common anal problem. Nearly always in the midline, usually posterior, and sometimes anterior in women. 20% of women with heightened sphincter tone will have some sort of fissure in the anterior location. So those are the two places that you can get the fissure. This particular patient has 2 of them. She had one after vaginal birth, and then the other one was this was chronic basically. If lateral, then need to think of other causes like Crohn's, STDs, AIDS, biopsy those if you find them during the EUA, and if you don't find them during EUA and you're doing an EUA, sorry, if you don't find them in the office, then you can biopsy them as well. I biopsy the edges. Sometimes I also do a punch biopsy of that area as well to see if there's a depth is of this particular problem is higher, or it's a deeper involvement if there is an anal cancer in there. Be wary of the low sphincter tone and fissures. I have not done a house flap or any of those flaps that they mention in the books because it's very rare to have these patients just come with low sphincter tone and fissure. I've found these patients have usually some sort of other pelvic floor disorder or some fibromyalgias or some other pain syndrome that fixing this alone is not going to help their problems. Anal fissure, the way I decide what to do is if in acute pain and they cannot sit in the clinic comfortably and they're just sitting on one side or walking around, or it appears to be a chronic fibrotic appearing fissure, then I do a sphincterotomy. I counsel the patients and there's a star sign or asterisk over it because I'll tell you how I do the sphincterotomy. But if the pain is only during the BM, then I start with a conservative management. I don't take them to the OR right away for this. Fiber and sitz bath, 2% diltiazem cream. I don't do NTG because the literature suggests they have similar efficacy, but NTG has a little bit more side effects of headache. Insurance in my area has denied Botox more times than they have approved it. So I do Botox if they get insurance approves it, but sometimes they just don't. Like I know that whatever the Medicare of Iowa does not cover Botox for this particular purpose. And I filed appeal, second appeal, and it gets denied. So I don't do Botox majority of the time. Either I'm doing with conservative management or I'm doing with sphincterotomy. And I don't do classical or tailored sphincterotomy, which is along the length of the fissure. I just use a small right angle. I learned it from Dr. Fig in my fellowship. And I just cut the last few fibers. I actually cut a little bit less than I learned. So I've realized it's always easy to go back to do something else than to have some sort of incontinence. So I cut 2 to 3 millimeters microsphincterotomy. There was a paper from Thailand. They were doing it some sort of a modification of tailored sphincterotomy that they labeled as microsphincterotomy, where they were just, their hypothesis was because the fissure is there and has exposed the muscle, that muscle is not working in conjunction with the rest of the sphincter muscle. It just has become fibrotic and it does not have the same physiological expansion and dilatation with bowel movements like other rest of the muscles. They were cutting just the last few fibers, couple of bands, and they were showing a healing rate of 92% compared to the 95 or 98 with classical or tailored. So I said, well, 92 is good, and they had 0% incontinence, zero. So I have had good results with that that stuff. I had to repeat a Botox on a very bulky and muscular guy, but I just had to do one Botox. I've done like more than 80 sphincterotomies alone last year. So they have good results. Perineal abscess, the pain, this is the one that they will say they have constant pain or got better when it burst or it just filled up and they felt like they were sitting on a cherry or a berry or whatever the size. If the call comes from the ER, unless it's obvious and the ER physician can tell me that, yeah, I can see it, it's right there protruding, I try to get imaging. I know it's frowned upon, but I get a CT pelvis with contrast. It tells me the anatomy, number one. Number two, some of them have been drained in the past as well, so I don't know where all the extensions are. And then I can decide about the possible location of my incision. And if there is any complex abscess associated with that, that is also pretty reasonably seen on a CT pelvis with contrast. And I always ask them about their IBD symptoms. As I said, I diagnosed 2 patients, 22 and a 17-year-old. They both had Crohn's disease, but their presenting symptom was a fistula. Drainage is the answer whenever you see a perineal abscess. Antibiotics, if the exam and the CT does not show any fluid collection. So here again, the CT is helpful. If there is nothing to drain, I would not do any justice by taking them to the OR and just draining it or giving an incision only to find there's not much. Or the patient is neutropenic or immunocompromised, because if you do IND in that area, it can cause sometimes perineal necrosis. And I don't do drainage alone if there is immunocompromised or IBD, because I do antibiotics with the drainage. I still drain it, but I do antibiotics for those people. It just helps with a post-op recovery in IBD, Flagyl 250 milligrams daily after after IND for 2 weeks also decreases the amount of drainage from the tissue and from the wound. I need to tell the patient that there's a 1 in 3 chance of anal fistula formation. Sometimes people quote up to 50, but I've found it is somewhere between 30 to 45% in the literature. So you don't want your fistula that will develop to be a complex one, and you want less muscle involved, so put the incision as close to the anal verge as possible. I do not pack it. Some people do. In my practice also, there are some partners that do it. Some put Melon-Cort catheters. I just make the drainage hole bigger and irrigate it out, and that's all I do. And it seems to work just fine. So anal fistula, the patient would say that it fills and drains, and they feel a bump near their anus. So, and to call it a fistula, you have to identify the internal external opening. Sometimes internal opening is obvious in the clinical exam in the office, but majority of the times it may not be obvious, to me at least. So there are two ends of the fistulas. Again, one of favorite sayings from Dr. Fig, who said, if you cannot use the external end to find the tract, and if you can find the internal one, you can use it. I used it on a BMI of 43 patient with a truck driver who has, they could not find a tract 3 times. Every time they'll EUA, and then he'll come back another abscess, another abscess. So I used the internal opening, and turned out that his fistula ended somewhere between that sphincter and would never reach to the outside, and then there will be a separate hole to drain it, forming a weird curvilinear tract on the MRI as well. So the MRI says the fibrotic tract ends right at the external sphincter, but then there is no tract to follow. But the guy kept on coming back with abscesses, and something kept draining on his skin. He just didn't know where it was draining from. So I used the internal opening and then tried to probe it. Turns out the tract was going in a different direction. Put a CTEM, he's fine for last 1 year. He doesn't want any surgery because that further surgery, because he was scared that he will develop incontinence. Estimate sphincter muscle involved. Consider staging fistulotomy. If you are trying to do a fistulotomy, then I always do the first surgery as CTEM placement. I have never done fistulotomy in the first go, never. Doesn't make sense to me. Even if there's no abscess and I'm seeing the patient for the first time, I just put a CTEM first and then always do a staging fistulotomy later. I was not sure what was the CPT code for this, so I recently found out, even after 14 months in practice, that it's 46285 for a staging fistulotomy. And that's also for the lift that you can use this code. And recurrence is better than incontinence. And so there are few types of fistula. Most common is the intersphincteric, because that's where majority of the glands end. Transsphincteric is there too. This is frequent. The suprasphincteric, these are uncommon, and the extrasphincteric are rare because they form with diverticulitis or some sort of other pathology that is coming above and beyond the sphincters. There's another type that I've seen in my practice sometimes now. The fistula tract was being probed. The probe went somewhere else. Now they have a different opening. There was no rhyme for a reason. I saw a patient who had a fistula tract deep in here in the rectum, not in the anal canal. And then I took him to the OR, found the real tract, which was in the left anterior location below the dentate line or at the dentate line. And there was a separate opening here that they had put a CTEM outside. So that was another type of fistula that I see in my practice a couple of times a year. They're hard, but they can be treated with endoanal advancement flap because it's not a real tract. If you burn that and then put a CTEM in the real one, these ones really heal well with endoanal advancement flaps. I've done this twice last year, and then both of them healed really well compared to some of the ones that I've done for the original fistula, and it fails 50% of the time. Anal fistula, the things that I do a little bit that I've worked for me is I remove the tract. I just, in fellowship, we used to open the fistulotomy, but leave the posterior wall or the back wall in there, or burn it, or curate it completely. I just remove it just by Bowie or a scissor or knife or any which way. If I have to remove it, I'll remove it. Then I approximate the sphincter muscles with Weichel figure of 8 intraop. At the same time, I'm doing whatever muscle amount I'm cutting during fistulotomy, 10%, 20%. If I'm able to isolate that, I'll do a little bit of an overlapping figure of 8, including the tissue in the back. So I don't leave any dead space behind the muscle so that it cannot form another tract. I always leave, sorry, I forgot to put that line. I always leave the first suture that is directly under the anoderm as my guide or a keystone suture, and I put a tag on it. and the rest of them I follow. I just want to make sure that I'm not able to dip into that when doing endoscopy, so that there's no chance of having another tract to form. If the internal opening is not found, I can tug on the tract from externally. I use hydrogen peroxide. I've learned from one patient, I used around 10 ml of hydrogen peroxide undiluted just to find the tract. The hydrogen peroxide went into tissues, and then she had horrible pain for next 2 days. So use minimal amount needed and dilute it. You don't need 3% or whatever percent to come in that brown bottle. I dilute it half and half, and I use as minimum as possible. I use a 2 ml syringe now, and an angiocath, or 10 ml syringe with this bigger angiocath, so that the pressure is still enough, depending on what's the size of your external opening. Or I simply come back another day. I don't do fistulotomies in midline. I don't have any good data to support why not to do them in the midline, but I've realized that if you do in midline, they cause long-term functional problems. Even though the sphincter is intact, somehow they will have pain or some scarring. I'm not sure. Just the same way that the fissure happens in the midlines, there is something problematic about doing a fistulotomy in midline. Uh, Sometimes a fistula plug may be helpful. Do not discount it. All those clinical practice guidelines says it's not something that should be offered and has lower healing, and everybody should use it as per their discretion. In the real life practice, I didn't do them for the first year, but last few months I've started doing it. I did approximately 12 in last 3 months. Only 2 of them were successful. But the way I look at it is, the paper will look at it as a success rate of 2 out of 12. But the way I look at it is, I didn't have to do any fistulotomy or anything in 2 out of these 12 patients, or a lift procedure or endoinal flap that had a chance of failure, and I'm causing more changes in the anatomy there. If the plug fails, the worst I have to do is put a seton again for 2 months or clean it out. But there are no long lasting consequences from it. So far, I've been I do it in anywhere there is a complex fistula. I try to do it once. If the patient is not amenable for any chance or any surgery, if you recognize the patient is this one that even with touching them or doing something in that area causes severe pain, then I just do a plug. Try with a plug. If they fail, then I switch to a more definitive surgery like a lift. I did some endoanal advancement flaps on their own without doing the lift. Maybe I was not just good at it, but I could not get more than 50% healing rate. So I now have switched doing endoanal advancement flap along with the lift procedure. I get around 80% closure rate for them. Still not all the way that initial paper from Thailand had suggested about lift being 85 to 90%. It is lower. And if you mix the two together, it makes more sense because you're first shortening the tract and also you're closing the internal opening. So that's why if I have to do any advanced procedure, then I'll do it together, both of them. And what are the lessons I've learned in the last, well, less than 2 years, 4 more months? Have a spiel ready for a quick anal anatomy lesson and the defecation process. Because most of the time when you're talking to the patient, I use a Kramer book for the anorectal anatomy, and I tell the patients and I write all the stuff on them, whatever I want them to do so that they can take it, read it. But they want to know as well how it works. Oh, yeah. And then they have better understanding, then they are following your non-operative plan, which sometimes feel like we have not given anything like fiber and water. But if they know what they are doing it, why they are doing it, they will do better. Uh, Operate only if you can help. I try to find a solid reason for the patient's problem in the office before I head to the OR. If I can't find anything, then I tell them this is just for EUA. If I find something that I can treat right away, I'll do it, like putting a C10 or putting Botox if I can get it. Sometimes I'm not been able to get it. But I do not do a fistulotomy or a hemorrhoidectomy unless there is a thrombosed hemorrhoid or some other reason. Even then I evacuate in the EUA part. It's just I like to talk to them and tell them exactly what we're going to do, or a couple of different possibilities, but never like, oh, if I find something in the OR, then I'll do it accordingly. Have to do it, do the minimal stuff that does not alter the anatomy. Admit when you don't know what the problem is. There were 2 patients that were sent to me. I recently remember they had Botox injection 4 or 5 times, 1 or 2 LIS in the past, still continue to have pain. On my exam, I feel their tone was normal. They had good squeeze, good relaxation. They did not have typical pain. So I told the patient, I don't know what is causing the problem. I don't see any fissure on my exam. I would not be doing anything. When he says it hurts, I said, I'm sorry, I don't know, but I can tell you what to do. And I tell him for pelvic floor therapy and biofeedback, put him on fiber, water. Haven't heard from him last 2 months. Probably try to switch the surgeon or he's happy one of the other. But I told him, if I cannot help you, I certainly don't want to hurt you. More patients than you think want to get hemorrhectomy because they don't like the extra skin. So very small hemorrhoids, I didn't even think they were causing problems, but the patient said, oh, they interfere with hygiene. And said, okay, take fiber, do this. She did all of that and comes back in 2 months and said, I just don't like them. Just can you please remove them? So that has happened more often than not, that patients want to get hemorrhectomy because they just don't like that extra skin. Sometimes that can be just a good enough reason, and then you cannot write that in the note, so you have to ask some questions, ask them what way are they bothering them. It's just cosmetic. Most of the time patient will say they cause some itching, or they sometimes cause interruption with wiping. They keep on wiping a little bit more every time. Counsel well, not just complications. I know we tend to say you can have retention of urine, have sepsis, this, that, even from small surgery, you can have stroke, MI, death. Those are rare, but the post-operative recovery is a true process, which every one of them will go through to a certain extent. So I tell them this is one of the most painful surgeries, the pain, how much time away from the work they will need. These hemorrhoids are not a separate organ themselves. They can come back. Give 2 to 3 points for them to follow. Like I tell them not to sit longer than 3 minutes. Make sure you continue your Miralax and Metamucil and don't strain. When you're in the OR and you don't know what is going on, how to deal with this problem, just don't make stuff up. Just like trying to put a probe, finding the whole opening, and you just want to finish it, so make another opening. Just don't do that. It's not helpful. Familiarize yourself with the varied anal pathologies. See it in clinic and read about it. In our group in 2023 class, we have seen Kaposi's sarcoma. We have seen a non-fungating squamous cell carcinoma. I have personally seen a Merkel cell carcinoma at the anus. So things that I could not think of, I've seen them. But just do the biopsies, get the diagnosis, and then try to see what the best you can do. Well, that's about it, guys. I didn't make any other slides in terms of, I thought I will give chance to ask questions, and then AIN, other ones, I mean, we can cover them later, or we can have another session. Those are my slides, and I'm happy to take any questions.
Thank you so much for the talk. I actually had a question.
Go for it.
Find it difficult as a trainee to really assess the bulk of somebody's external anal sphincter when I'm considering whether or not to pursue a fistulotomy. Do you have any tricks that you use, like hooking it laterally, or potentially estimating it in more of a three-dimensional capacity that would help me?
Yeah, so in the office, I try to ask them to squeeze. And once you squeeze, you can feel the bulk. So that way you know. Because in the OR, I don't do any paralysis, but I always use general anesthesia. I just don't want to do any anal procedures under MAC. I just don't do them because a couple of times patient has tried to lift their legs and it comes out from those lithotomy stirrups. And there's a safety issue sometimes. You can get hit in your neck. I know a faculty in Nebraska got that. They had a subluxation in the disc. Regardless, so I cannot do that in the anesthesia, so I try to do it in the office. I ask them to squeeze to see how long they can squeeze it. I keep watching it, and then the moment they relax, you can get an idea. So if they can do it around 30 seconds or more, they will have a good external sphincter. That's one. Number two, when I have a finger, like when we had DRE, digital rectal exam, I ask them to squeeze on my finger like you're trying to hold it in. And then I see if there are any gaps or any problems, especially in the women, they have given childbirth. Try to see what's the ring feel like. If the ring feels nice and thick, you know that there's a good tissue there. In the OR, if I am doing a fistulotomy or a fistula for a person who has been sent to me by someone else, I always get a baseline MRI. So that's another one. I can see the sphincters, how much are they done and what has been done in the past. Because sometimes these op reports are not what has been done exactly. They describe, I found it at 12 o'clock, then at 6 o'clock, then at 1 o'clock, and then I get confused. So I get an MRI to make sure. That's another way to figure out how much muscle. And the last is, if you think you're going to do a fistulotomy, I always tend to a side of more conservative way, like of doing a fistulotomy. If you see the tract is nice, small, even then I do approximate the muscle. I do a little bit of dissection to get the muscle out and approximate it. So even if you cut a little bit of extra muscle that you think maybe cause some problems, you approximate it, and so far it has been given me good results. But I don't have any tool to see how much is the sphincter they have involved in their lateral or their external or internal side, unless you have an objective data. I don't have anorectal manometry here at all, before or after, or endo and ultrasound. That also can tell you about the bulk of the sphincter.
Great, thank you.
Yep. I didn't answer your question, Jordan, at all. Sorry.
No, it's helpful. I didn't really consider, and it's a little bit difficult for me as a trainee because sometimes I don't meet the patients in pre-op or in the clinic where I can do a detailed exam, but definitely when I start practice, adding that information in will be really helpful. One of the questions in our Surgeon platform was just a little bit more on the discussion about a horseshoe abscess and fistula management.
Okay.
Do you typically place a seton in the posterior midline and divide the internal anal sphincter, or leave it alone and deal with it later? Can you just detail how you take care of these?
So yeah, I've seen a couple of horseshoes in the last 1 month. The first thing I always do is get a CT scan because I want to make sure the horseshoe tract is from the top or from the bottom. I've seen horseshoe tracts also anteriorly, not just posteriorly. And the anteriorly, because of the perineal body, is difficult to identify. So get a CT scan. I've told that in my slides. I do the CT scan. Once the CT scan is done, then I don't try to find a tract in the posterior midline if I can't find it, because at that time it's very soft and you can make a different tract. But if the person is coming from recurrent abscesses, then you can sometimes find a tract. But I do modified Hanley procedure every time for those. If the CT confirms, then I base my initial incision based on either I'm releasing the deep postanal space or is it in the superficial postanal space. Because if it's a deep postanal space, you have to cut that raphe that you're cutting during APR, or doing during LAR, that inococcygeal raphe. You have to cut it, otherwise there is no other way to reach deep postanal space. So that's where it is, the communication between the deep postanal or superficial postanal space. If it's just superficial, then I just put a small incision in the skin and then connect it from the two sides that the incisions we have given on bilateral buttocks. If it's a deeper one, then only I'll cut the deep postanal space, because I do not want to violate that space, because that has something to do with keeping the sphincters nice and work. I don't know. I don't do anything in midline. I hate doing that, because if the fissure happens in midline, there is some reason for it. I don't want to give my incision there in the midline too.
Yeah, and earlier you were discussing your like macro sphincterotomy.
Not mine. I just read somewhere.
The discussion on that you were mentioning is that picture, all the exposed muscle. You said you don't take all of that. Is that correct?
Yes. So I do it on the left side, lateral internal sphincterotomy in the left hemorrhoidal column, because I'm right-handed. People who are left-handed, they do better on the right side because that they can dissect. So I do a small right angle, the smallest right angle. And then once I have developed the submucosal plane between the internal sphincter and the hemorrhoid, and then I do a straight tonsil or some fine hemostat to just go in the intersphincter groove. And then I use a right angle to hook those fibers and then isolate them over my right angle through that small incision. It's a less than 3 mm incision. Once you make that groove, and then that way you can push the hemorrhoidal mucosa away, and then you have an intersphincteric groove, and then you hook that muscle over the small right angle. And the distal most 2 to 3 mm, I cut them, no matter how big the fissure is. I don't cut all the way, like the length of the fissure. I never measure the length of the fissure. The other thing I do is I cauterize the fissure as well and clean it out to promote healing.
Right. Right.
Those are the two things I've been doing. I only have one paper that showed about microsphincterotomy from Thailand. They did it differently. They used a small incision, used a laser, and then cut that. Obviously, I don't have a laser. I don't have the microscope, so I just use a bigger incision, but cut the same amount of muscle that they are trying to cut. They are cutting like 3 or 4 fibers in there, and mine are the similar. I just isolate that muscle, but only cut few fibers, because you can isolate as much muscle as you like, but you can decide how much you want to cut out of it.
Okay. I find it kind of difficult sometimes to assess real anal tone in patients with fissures because they're so exquisitely tender. How can you tell if somebody has like a poor, not a poor, excuse me, like a loose anal tone with an accompanying fissure?
So the fissure will not be either in the posterior midline. That will be one clue that you can find. I
Okay.
found it in an 80-year-old woman with a fissure. How many 80-year-old people are developing fissures? I've not seen them usually, so that was another kicker. I'm not trying to like diagnose right away. I'm just trying to gauge an idea that this is a trap. This is something that I should not become just taking like, oh yeah, I will do a sphincterotomy. Oh, this is very easily treatable. Nothing like that. This is something that is warning me that dig deeper. So then I always ask the incontinence questions. If a person has incontinence already, then I'm worried like, why would they be having heightened sphincter tone as incontinence? Sometimes prolapse can cause fissure too because it's coming down and it's expanding and they are able to push it, but it has already caused a tear in the anoderm. So that one also I've seen here. In those cases, I can see that the sphincter tone is poor, but I don't have anorectal manometry, so I can't tell you exactly how to measure it. But I've been able to do it based on the DRE, based on their history. If they have older age, if they are not able to have even if they have stress or urge incontinence of their urine, then also I'm worried like this may not be coming from heightened sphincter tone. In those patients, I can tell you the other way that if I find that I can't do an exam because of pain and they are tightening their muscle, then during EUA, the minimum I will do is do a Botox. Because in those cases, I will try to get Botox approved because this is a diagnostic test just like you do for SNS.
Right.
That you give a 2-week trial and see whether they have better control of symptoms, and then you place the permanent pacemaker. Same here, like you try Botox. If it works, then you know that they will be better served with either repeat Botox or a sphincterotomy. But if they don't, then you know that there's something else.
Right. And then if you have some incontinence after a Botox injection, you have some clue as to whether or not you can
I
safely divide the sphincter.
I never do sphincterotomies on people who develop incontinence after Botox because then I can just repeat the Botox or send them or NTG or diltiazem or find other cause.
Mm-hmm.
But I will only do sphincterotomy, fistulotomies, unless I'm for sure that I'm not doing something stupid.
Right. Okay. This is maybe a little bit more of an embarrassing question for myself, and I'll just own it. And
Fine.
I have a little bit of trouble sometimes when patients are very squirmy telling internal from external hemorrhoids when it's in the emergency department and I don't have great equipment and they're not very well sedated. So when I see those hemorrhoids that you showed, to me, they don't look thrombosed because they don't have that kind of grape appearance to them and purple. But I still see the anoderm over the top of them and it's smooth and you can see that transition. Is that kind of generally what you look for in those scenarios?
No, if they are in so much pain, I don't even bother
Yeah.
looking there. I did not discuss this, but if I have to evacuate a clot, I'm doing that in the OR. I don't do it in the ER. I just don't do sedation at all for any kind of anorectal work. Unless the ER person can drain the abscess on their own and can do the local, I do not do anything without anesthesia for the anus. I just don't.
Okay.
So in those cases, I take them for the EUA because that is something controversial. I did not want to put it because then it polarizes people and then said I'm giving a wrong message. So I remove few of the things, but people say you can give local, lancet, and cut it. The patient is in so much pain. The first thing I want to do is stop stop them from being grumpy and angry, and they've already waited for 4 hours in the ER. The intake was slow because there are so many people with cough and cold. They stayed in the ER 2 days ago and then they went back because nobody was problem giving their time because they only had hemorrhoids. Like that's where the person starts, and then I just don't want to go into that detail of, oh, I'm sorry, I'll just tell them we will make you comfortable and we will do the best we can. The least I will do is remove some clot. If I don't find anything, if I find a pus, then I'll drain it. And if I find a fissure or something, then I'll just come out and after doing the exam, I'm not doing a sphincterotomy.
Yeah, I got to be honest with you. I feel the same way. I feel like if, the ED is calling us for a complex abscess that's like large and difficult, I feel like our benefit as colorectal surgeons is we have access to tools in the OR.
Yeah,
So,
man. Like e- even if you get the best result in local, the person will not forget how you made them feel.
Yeah.
You have to realize the patient wants to feel better from the pain, not from the hemorrhoid. He doesn't care what's hanging over there sometimes. He just wants to get rid of that pain for some moments. So if you can get those, they are very appreciative.
So in regards to the kind of like when you have a acutely thrombosed hemorrhoid, are you just doing clot evacuation, or do you actually do excision as well when you get to the OR with those?
So if I'm in the OR, I will just remove that. If I just want to excise, I have done it in a couple of times in patients who delivered, and now they have thrombosed hemorrhoid. I do not want to do a hemorrhoidectomy on that stretchy tissue yet. So I will take them to the OR. I'll just excise the skin on the top with the ellipse, and I evacuate all the clot. Because once you evacuate all the clot, then you actually see the bleeding. And then you can control that bleeding with Bovie or a suture. And I have had some people who had clot evacuation done by the ER physician, and then I saw them recently, last Friday. I saw them, they had put 2 Prolene sutures because they were bleeding and they could not control the bleeding, and the guy had rethrombosed. And I asked them what was done and said, oh, they took a blade and then did this. Because I see an incision, I don't see any cut or any skin missing. So there is very high chance of rethrombosis if you leave some clot behind. So you have to remove all the clot and then you get to the bleeding so that the grape can become a raisin. That's how I explain the patient, because right now it's grape. My job is to make it a raisin and make it a completely wrinkled skin so that it doesn't hurt.
Yeah. All right. Well, great. Thank you so much for the talk. I think our chat is, all the questions are done. So
no problem. Thanks,
great.
guys. Yeah.
Have a
Thank you
nice
so much
Monday.
for the opportunity to talk. Thanks. Bye-bye.